why we are aiming toward personalized nutrition. I will talk a little bit about omics and artificial intelligence. What is the role of these in neonatology in the future? I'll talk a little bit about the maternal microbiome and metabolome and its implications, multiomics relationships to immune development and epigenetics and subsequent phenotype, human milk multiomics, and can we personalize this, and differentiation of intestinal injuries that we are currently calling NEC, and then just give you a little summary where we're going in the future. So some of you may be familiar with this. This is the United States Department of Agriculture pyramid that was developed in the late 1980s, early 1990s, that told the population what kind of foods we should eat. And the base of this pyramid was bread, cereal, rice, pasta, and then vegetables as you go further up, fruits, and then fats, oils, sweets at the very top. We are now recognizing that this is really a problem, that this pyramid was not correct. And by promoting the consumption of all complex carbohydrates and eschewing all fats and oils, the pyramid provided misleading guidance. In short, not all fats are bad, and by no means are all complex carbohydrates good for you. So we've had some changes to things like My Plate. And again, these are all based on Gaussian statistics and what we think is best for the population rather than us as individuals. The American Academy of Pediatrics in 2012 offered some guidelines for preterm babies. And I quote here, "The potent benefits of human milk are such that all preterm infants should receive human milk. Mother's own milk, fresh or frozen, should be the primary diet, and it should be fortified appropriately for the infants born weighing less than 1.5 kilograms. If mother's milk is unavailable, despite significant lactation support, pasteurized donor milk should be used. Quality control of pasteurized donor milk is important and should be monitored." One important thing to remember in this statement by the American Academy of Pediatrics is that they say that it should be fortified appropriately for the infant born less than 1.5 kilograms. What does this mean? We are still not sure what the meaning of this is. So one question that we have is, do we all respond the same to the same food intake? I'm sure all of you have heard the statement that I eat all I want and I never get fat, or I eat very little and I'm still getting fat. So different people respond very differently to the same diet. This is something we are just beginning to recognize the mechanisms for. Here is one article that was published in Nature Medicine, and there are several articles that have come out in the last few years that are showing the importance of personalization. This is a study that was done in the UK by the PREDICT group. And what they did was look at 1,002 twins and also unrelated healthy adults. And they gave them a specific diet and then measured the lipemic response, glucose response, various outcomes. And they found that person-to-person factors such as the gut microbiome had a greater influence than did the meal macronutrients for postprandial lipemia, but not so much for the glycemia. And these findings were independently validated in a United States cohort with 100 people. And then they were able to develop, using artificial intelligence, something called machine learning to predict both triglyceride and glycemic responses to food intake. And they now think that they can use these machine learning techniques to personalize nutrition for individuals. We have several studies showing that this is very important, that we can personalize. So why personalize? Well, here at the bottom of the slide, we have the metabolic syndrome. And certainly for adults, we are seeing that there are ways that personalized nutrition can prevent the development of the metabolic syndrome. But what about babies? Here we see two babies, one born at 23 weeks gestation, one born at 29 weeks gestation. And these are obviously very different babies with very different requirements for nutrition. One size does not fit all. What about babies who are born IUGR? We are beginning to find that those babies have very different nutritional requirements than babies who are born appropriate for gestational age at the same gestational age. And we also know that there are several adverse outcomes that are associated with suboptimal early nutrition, and these include NEC, BPD, retinopathy, late onset sepsis, growth failure, neurodevelopment, and even metabolic syndrome that Professor Simeone will be talking about in a couple lectures. Now, over the past couple of years, we've had these initiatives, and here is one initiative that has been initiated in the United States. And this is an article, a review by Dr. Rogers and Francis Collins. Dr. Collins is the leader of the National Institutes of Health in the United States. And in this review article, they talk about the goal of personalized nutrition. And this is to bring fruition, the promise of the science of precision nutrition and advanced understanding of the vitality of food and health. Now, how do we go about precision nutrition? Well, we think that one important component is going to be multiomics. I had mentioned before something about the microbiome being really important, and we will talk about that shortly. But what are some of these omics that we are discussing here? There's the genome, that's the DNA of the individual, the microbiome, the transcriptome, that's the RNA that is transcribed on the DNA, then the protein, the metabolome, the epigenome, and then the metabolites that are produced, and then what individuals are exposed to in their environment. All of these are important factors for personalized nutrition. In the late 1980s, early 1990s, a large initiative was undertaken globally to look at the human genome, to look at the sequence and to find the actual sequence of the adenine, thymine, guanine, and cytosine of the human genome. And after about 10 years and several billions of dollars, this was successfully completed. And now we have the capability of using the human genome to help with personalization and to actually be able to define certain kinds of diseases and conditions. However, when it comes to nutrition, there are the same genetic variants often contribute to final outcomes, but these depend on the environment and the genetic background. Remember that DNA is only a template, and how this template is used differs depending on numerous influences. We can look at metabolites in one's body. We can look at the urine, the feces, the blood, and we know that these metabolites, many of these come from the microbiome. And these serve as nutrients and can also serve as signaling molecules by which bacteria communicate, not only with the host, but also with each other. Most of these metabolites are poorly characterized, and when we think about metabolomics alone, we have certain challenges. They're highly pleiotropic, and what this means is that they have more than one effect in different situations and over time. We also don't have good norms. In other words, a metabolic taxonomy, which is important during early development, especially in pregnancy and early life, when changes are rapid and highly responsive to environmental perturbations. So we need to develop this metabolic taxonomy. What is normal, so that we can compare the abnormal to what is normal? Now here, I want to show you on the left side of the slide a picture of this elephant and a parable. This is a Hindu parable that gives us some idea of why we have to have multiomics. And The Hindu parable talks about the 6 blind men of Industan. Each one of these blind men was asked to feel a portion of an elephant. One blind man goes to the side of the elephant and says, "This feels like a wall." The other blind man goes to the tail and says, "This is a rope." The other one goes to the tusk and says, "This is a spear." So all of these blind men had a different concept of what they were feeling. They got together, they argued, and they were not able to communicate. And so they were not able to determine that this was an elephant. Had they communicated correctly, they may have been able to determine that this was an elephant. Well, we have the genome, we have all of these different omic layers. And if we can use them to communicate together, we can develop mechanistic patterns that will give us biomarkers that will give us a much better understanding of what is actually going on in the body. And with these multi-omic technologies, we generate a tremendous amount of data. And with this tremendous amount of data, we have to use some of the newly developed techniques of artificial intelligence. So again, why multi-omics? Each type of omics data may provide a list of differences associated with a disease or outcome. These are associated. That does not mean that they are causal. But individually, they can be useful, but it's limited because they only give us correlations. Then these can be hypothesis generating. But if we integrate them together, they more strongly define patterns associated with and perhaps even causative of diseases and outcomes. And these can more readily and accurately lead to preventative and therapeutic targets. Now let's talk about a couple of these omes in more detail. What about the microbiome? Why all the fuss? There are at least 15 books now on the microbiome. Here's just some examples. There are over 86,000 publications on the microbiome now cited in PubMed. Why is this so important? Well, we are beginning to recognize that the human microbiome actually is sort of a second genome. And on the skin, we have microbes that we never recognized existed before using newly devised techniques that we see at the bottom right portion of the slide. This is 16S RNA sequencing and total microbiome DNA sequencing. In our gastrointestinal tract, we have huge number of taxa of microbes that we never knew existed before. And we are beginning to recognize that we can not only identify them, but also we are beginning to learn how to show their function using transcriptomics and proteomics and these multi-omic techniques. We know that there are microbiome perturbations that are associated with several diseases, including central nervous system diseases, including autism spectrum disorder, depression, and then certain other illnesses such as lung diseases, gastrointestinal diseases, obesity. When we talk about the gastrointestinal tract in the microbiome, there is an aboral gradient of the number of microbes that we see and also their function. As we go down in the gastrointestinal tract, we see increased numbers of microbes. So that in the upper gastrointestinal tract, in the stomach and the duodenum, there are very few microbes. But in the ileum, we see approximately 10 to the 6th to 10 to the 3rd to 10 to the 7th microbes. And in the colon, we see 10 to the 11th microbes. So huge quantities in the bottom portion of the gastrointestinal tract. In the ileum, there's a lot of gastrointestinal associated lymphoid tissue. So in the ileum, the role of the microbiome is largely immunologic, but in the colon, it appears to be more of a metabolomic role. Now, what about these immunologic and metabolomic roles? At the top of this slide, we see this insect. This is called a termite. And certain of us who may have wooden homes are very afraid of these termites because these termites can destroy our homes. Why? Because they can eat wood and digest wood. They have certain enzymes in their gastrointestinal tract called lignases that can break down this complex carbohydrate called wood. They also have certain microbes in their gastrointestinal tract that can break down very complex carbohydrates, such as those found in wood. We are beginning to find that individuals who are fat versus skinny have very different microbiomes in their gastrointestinal tract. And if you take the microbiome from the fat individual and put them into germ-free mice, early on in life, those germ-free mice will then turn into obese mice as they grow up. So this is telling us that the microbes in the gastrointestinal tract may be very important in terms of the metabolomic function and development of obesity and type 2 diabetes and various other problems that we see later on. We also know that there's an immunologic role of the microbes. And here we see the lumen of the gastrointestinal tract. And in the lumen of the gastrointestinal tract, depending on the types of microbes present, there is interaction with the intestinal epithelial cells and also certain cell types, such as this dendritic cell. This dendritic cell has the capability of detecting certain types of microbes, and when they detect certain types of microbes, the surface of this dendritic cell changes, and this dendritic cell in the submucosa interacts with undifferentiated lymphocytes, so that these undifferentiated lymphocytes will then differentiate into either T effector cells, which are very important for fighting infection, or other cells which are important for tolerance. So this is a very important component of the microbiome. This is some data from our own laboratory here at the University of Florida, where we looked in preterm babies. And this is an example of how we can look at more than one ohm and relate that to what is going on in the baby's gastrointestinal tract. So at the top, we see clinical events such as late onset sepsis, cons sepsis. The next, we look at antibiotic treatment. The next, we look at the types of microbes that are present, the relative abundance of microbes, depending on whether antibiotics were used or not, and how these relate to the clinical events that are going on. We can relate these microbes to the type of feeding. And then we can look at inflammatory mediators such as CRP, when these inflammatory mediators increase in relation to the types of microbes in the gastrointestinal tract. And then we can also look at the types of cytokines and inflammatory mediators present in the gastrointestinal tract. So this is just an example of very limited multiomics, but we are still not, in this study, putting them together and integrating them. And this is where we want to be able to go in the future, so that in the first 1,000 days of life, we can look at maternal nutrition, over and undernutrition, various aspects of how the mother eats in her diet. And then we can look at neonatal and infant nutrition, and then look at the microbes in the mother and also the baby, and then evaluate how this relates to the types of metabolites that are present and how these metabolites actually relate to transcriptional factors and also the epigenome, which Professor Simeone will talk about in a couple of days. And this is very important, not only for adverse events in the neonatal intensive care unit, but how these babies may grow and have problems later on in life. So here we see this wheel with large amounts of data, genetics, personal data, dietary intake data, meal content, etc. Huge quantities of data. And how do we manage these large amounts of data? Well, we are now in this new age of artificial intelligence, which helps us. We have tools for integration and use of this artificial intelligence, such as machine learning, neural networks, systems networks. And one of the things we are beginning to recognize is that neonatologists need to learn to speak some of these languages with engineers, with people who are artificial intelligence experts, so that we can have teamwork to be able to enter this new age of precision nutrition. Now, let's go back and look at this baby. Is there a role for precision nutrition in neonatology? And how do we best nourish this infant? Well, several years ago, even in 1976, one of our colleagues, very well-known colleague by the name of Eckhard Ziegler, published a paper in Growth and showed that there are different energy stores in the fetus and in the newborn. If we look here in weeks of gestation, 24, 26, 28, 40 weeks gestation, here's the differences in weight, here's some water differences, here's the protein difference. You can see the lipid difference is huge in the 24-weeker versus the baby that's born at 40 weeks gestation. So the energy stores are very different in the 24-week gestation versus the 40-week gestation baby. And so this means that we have to take this into consideration when we are nourishing a baby like this. So here is a Tour de France cyclist. This Tour de France cyclist uses about 7,000 calories per day. And if this is a 60-kilogram rider, this 60-kilogram rider is getting about 120 calories per kilo per day. That's what this premature baby requires. What about protein? The fetus in the last trimester of pregnancy is getting about 4 grams per kilogram per day. So these preterm babies require about 4 grams per kilo per day if you are going to give them the same as their in utero requirements. And if we do a calculation for a 70-kilogram adult, that equates to 280 grams of protein, who we have actually found to only need about 55 grams. So here, this just depicts the large amount of protein that that individual, the adult, would be getting if we were giving that adult the same amount of protein on a per kilogram basis. As far as the AAP requirements that I talked about before, the AAP recommendations on donor milk, I think we need to take into consideration that we still have some real limitations in our knowledge. And this study, this is a study that was done in Canada by Dr. Debbie O'Connor and her colleagues, looking at donor milk versus preterm formula. And what they found in this study was that donor milk, trying to even provide with fortification, sometimes is not quite as good as preterm formulas when it comes to cognitive outcomes at 18 months, 2 years of age. So this is a potential problem. Here is the results summary of the results of this domino study. Donor milk-fed babies compared to formula-fed babies showed trends toward lower language and motor development. Donor milk-fed babies had higher cognitive neuro impairment scores and a trend toward higher language neuro impairment score. So we still need to be able to take that AAP recommendation and refine it correctly to be able to get the optimal results. Here is a Fenton growth curve, and Professor Fenton will be talking to us in December. And here's just one of the things that happens with Fenton in the Fenton growth curves with certain babies. You see the length, the head circumference, and weight falling off. This is a problem. Now, When we see this falling off, we try to respond to it, but the damage to that baby may already have been done. When we see this kind of growth faltering, it's already too late. We need to have indicators that help prevent this. And I think sticking to the old Gaussian statistics as seen in this growth curve are not the best way to go about it. So in the future, we will need to find biomarkers that will tell us how to best nourish individual babies. That does not start after the baby is born. This actually starts when the baby is still in the uterus. This starts very early, and we are beginning to recognize that the mother-infant unit is not just a dyad, it's a triad. There are nuclear and mitochondrial genomes that are transmitted from the mother to the infant, and so are some of the microbial genes. This serves as a second genome. About 35% of the metabolites in mammalian blood, including fetal blood, have a bacterial origin. It may not be a bacterial origin directly from the fetal gastrointestinal tract or the fetal or the amniotic fluid, but from the maternal gastrointestinal tract and from the maternal microbes. So the pregnant mammal herself is a symbiotic community, something that we call a holobiont. There are several groups now that are beginning to model pregnancy-related complications. And this is just from a slide from a recent article from Stanford University, where they are utilizing multiomics and various aspects of the exposures during pregnancy, and using complex data, including microbiome and different omics, to develop these networks that will tell us likelihood of risks for preterm birth, preeclampsia, and fetal growth restriction. Very fascinating new areas. Now, let's look at what is happening in the world today in terms of C-section rates and how this might relate to maternal nutrition and to the infant personalized nutrition. We know that in certain parts of the world, the C-section rates are very high. In fact, in some portions of South America, for example, in the private clinics, it's almost an accident if a baby is born by the vaginal route. What does this mean? Well, we are beginning to recognize, and this is a review article that I wrote with one of our maternal fetal fellows several years ago, cesarean versus vaginal delivery, long-term infant outcomes in the hygiene hypothesis. And epidemiologic data, even several years ago, suggested that those babies born by cesarean section delivery had a higher incidence of certain autoimmune diseases and obesity and certain other adverse outcomes. So why is this? Well, it's thought that perhaps that the microbes that the infant acquires during delivery may play a role. So if a baby is born by vaginal delivery, some of the vaginal microbes are actually provided for this baby, whereas a baby is born by C-section, those vaginal microbes do not get into the baby. And so this is the hypothesis that was generated, and several studies have looked at this relationship. And this is one study that was done by Dr. Dominguez Bello from New York University and published several years ago. And what they did was they looked at the microbiome of babies delivered by cesarean section versus vaginal delivery. And this is a principal component plot showing that those babies delivered by cesarean section, their stool microbiome looked a lot like the mother's skin microbiome. Whereas those babies delivered vaginally, those microbes in the stool of those babies looked more like the mother's vaginal microbes. So these are studies suggesting that the role of the microbe may actually be important. This is a study that was published several years ago, and the title of this was Partial Restoration of the Microbiota of Cesarean-Born Infants via Vaginal Microbial Transfer. What does this mean? Well, babies who are delivered by the C-section route in this study were given were treated with a gauze pad that was used to swab the mother's vaginal tract, and then that gauze pad was placed in the baby's mouth and swabbing of the baby's face. And what they found was that those babies who were delivered by cesarean section and had that swabbing procedure done actually had vaginal microbes in the gastrointestinal tract. So they found that this actually worked. However, the American College of Obstetrics and Gynecology came out with a statement urging against this practice of vaginal seeding, and they recommended against this because they did not think that this was yet safe. So the question is it possible to seed a discrete microbiome in these these C-section delivered babies? And there are now several studies that are evaluating this using specific ecotypes. What about the human milk microbiome? We have found over the last several years that human milk actually contains live microbes, and that these are not just skin microbes, these are actually microbes that are present in the mother's milk. There are several components that make the milk special by interacting with the intestinal mucosal immune system, and here are a list of these, and microbes definitely are one of them, and antibodies also appear to be important. Now, several years ago in 2011, this study was done looking at microbes in mother's milk. And what they did in this study was they took 16 mothers and looked at their milk samples at 1, 2, and 4 weeks after birth using 16S sequencing, and they looked at the relative abundance of different microbes. And here in this one mother, we see that at 1, 2, and 4 weeks after birth, these microbes are somewhat similar. But when you compare the S1 mother to the S2 mother, the microbes are very different. And all of these microbes in the different mothers appear to be different. This suggests a personalization of microbes depending on the mother's milk, depending on the individual mother. We know that the bacterial load is fairly large. So we see approximately 10 to the 5th to 10 to the 6th microbes in mother's milk over different lactational stages. This is the colostral, transitional, and the mature stage. These are the means. These are from individual mothers. So if we assume a microbial, an intake of 800 milliliters per day in a term infant, for example, and assume 10 to the 5th to the 6th bacterial cells per milliliter, this provides about 10 to the 7th to the 8th bacterial cells, which may be personalized daily, which is close to the dose used in most probiotic studies. So using the baby's own mother's milk personalizes the nutrition for this baby. Now, when we don't use the baby's own mother's milk, we can use donor milk. Well, we find that most countries pasteurize donor milk, and certainly the United States does this. And one of the reasons is to get rid of bacteria, to get rid of certain viruses such as CMV. And what does this do? This actually gets rid of some of the personalization of the human milk. It decreases alkaline phosphatase and bile salt stimulated lipase. And so these, the donor milk is very different than the baby's own mother's milk. We also know that over time, there is a personalization, a dynamic interaction between the mother and the baby. And this is one of the reasons why we support skin to skin care with having the baby very close to the mother. In the late 1970s, Drs. Alan Walker and Ron Kleiman looked at studies from animals showing that there existed something called an enteromammary system, where if a baby and a mother are closely aligned to one another, such as with skin-to-skin care, if the baby has certain microbes in its skin, those microbes may not be susceptible to the baby's immune system, but if the mother ingests those microbes, the mother can make antibodies and mount an immune response, and then pass that on to the baby in the breast. So this is the enteromammary immune system that has now been found with several studies in humans to be very important. Now, can we personalize donor milk with mother's own milk? We know that some mothers are just not able to produce adequate quantities of milk early on, no matter how hard they try. So we are able to get donor milk for those babies, but can we put in something that personalizes that donor milk for those particular babies? This is a study that we did in several years ago, and at the top of this slide is Nicole Cacho, and we have Graciela Lorca, who's a microbiologist, and Nicole is a neonatologist. And they did this study, which was published in Frontiers in Microbiology, where we took different quantities of baby's own mother's milk and put it into donor milk in different concentrations, 1, 5, 10%, for example, and then incubated it for certain periods of time, and found that between 4 and 8 hours of incubation, we were able to get a microbiome that looked very similar to the baby's own mother's milk. We also did some studies looking at the metabolome, and here we see donor milk and baby's own mother's milk, and here in between are the different concentrations where we see that there is a where we see the metabolome looking much more like the baby's own mother's milk with these different concentrations. So here we have pictures of two babies. One baby is a very low birth weight baby. I showed you this picture before. And what happens all too often in some of these babies is that they develop this very distended abdomen. And this is an example of what we call necrotizing enterocolitis. We have a problem here because over the last 50 years, there's been not much progress in terms of us really understanding this disease and being able to prevent it and treat it. But there's several reasons for this. One of the reasons has to do with us saving smaller and smaller babies, which are more susceptible to this disease. But another problem is that we don't have a good definition for necrotizing enterocolitis. We lump several diseases that we call NEC into the same data set. There are animal models that do not represent the disease that we see in preterm babies. And there's also a narrow focus on individual pathways rather than systems. And this is where artificial intelligence and multiomics is going to be important. So let me ask you this question. Would you please define necrotizing enterocolitis? I can tell you, I've been studying this now for nearly 40 years, and I cannot define necrotizing enterocolitis adequately. Here is a paper that looked at defining necrotizing enterocolitis. This was published a little bit over a year ago in Pediatric Research. And they summarize in this paper 8 current definitions of NEC and explore similarities and differences in clinical signs and radiographic features included within each of these definitions, as well as limitations. I'm going to posit to you that we should be getting rid of the term necrotizing enterocolitis because we cannot really define it. And there are different forms of intestinal injury that are actually imposters for necrotizing enterocolitis. And here we see some of these imposters. I'm not going to get into all these in any detail, but cardiogenic ischemia, variants of food protein intolerance, spontaneous intestinal perforation. These are all imposters and forms of gut injury that we are calling necrotizing enterocolitis. So in the future, where we need to go with this is use some of the newly developing AI technologies and multiomics, and start with making believe that we don't even know the term necrotizing enterocolitis. Let's go back to the 1960s and then attempt to identify all intestinal problems such as feeding intolerance, intestinal perforation, radiographic or other signs and symptoms of intestinal injury, and then utilize large, well-defined granular data sets along with newly emerging AI technologies to cluster the different forms of intestinal injury into clinically related phenotypes. Then merge multiomic-based technologies with newly developed artificial intelligence to obtain better understanding of the pathogenic mechanisms. These will need to be done over time prior to the development of the disease and not before. We have started this, and one of the studies that we have recently published utilized machine learning to differentiate NEC from SIP. And we took babies who had SIP diagnosed at surgery and classic NEC diagnosed at surgery, and we looked at different features prior to the development of classic NEC and SIP, put these into a machine learning model, and then validated this, and we found that there were certain features that were highly related to either NEC or SIP. And here we see receiver operating characteristics showing the accuracy of this modeling technique. Here are two different statistical models that show high precision of using this technique to differentiate SIP from NEC. We can do this with many other forms of intestinal injury, and also in the future using multiomics. So we will here begin with experiments that look like this. We will look at severity scoring systems derived from machine learning and use predictive analytics. We'll get timed samples from feces, saliva, blood, put them all together into this multiomic paradigm, and then get these network analyses which relate to early nutrition, adverse outcomes. We will be able to find biomarkers that tell us very early, before the actual problems develop, so that we can have nutritional, microbial, and other therapeutic interventions. So in summary, here we have H.G. Wells in the time machine. We have made progress in finding associations between early nutrition, maternal and neonatal, and short and long-term outcomes. But these associations are not enough. These associations are not well understood, but are amenable to analysis by newly developing technologies such as multiomics and artificial intelligence. Once these mechanisms are understood, we will be able to provide personalized nutrition for mothers and infants. And in order to accomplish this, clinicians, basic scientists, engineers, bioinformaticians will need to learn to communicate and speak similar language. Thanks for your attention.
Do you hear me?
Yes.
Thank you, Joe. It was a wonderful. I really enjoyed thoroughly your talk with a lot of new ideas, new insights, and it's really fun. It's a bit intimidating, I must say, but it's fantastic. I mean, I would like just to find out how you feel about, few ideas or few concepts. Something that struck me, probably is this most simple thing, was the metabolism of a preterm baby compared to an athlete, the cyclist or so. So sometimes we talk about premature baby, metabolic immaturity or so. I really wonder if these preterm baby are really immature, or they are sort of reaching the limit of their metabolic machinery as they tolerate as much energy as an athlete, a fully trained athlete. So, and the more I look in the literature, the more, or I do bit of some of the study, the more I realize that their metabolic machinery works pretty well and sometimes much more efficiently than in adults. So I think probably I like to hear your opinion, whether we should somewhat revise the concept that poor premature baby are metabolic immature, which is not all, sometimes is not the case, I think.
I think that's a fascinating idea. I think you are absolutely right. During different stages of development, we have different metabolic capabilities, and this is one of the things that I think that we generally think of the preterm as being sort of just not able to do a lot of these things, but their metabolism for certain capabilities may be much higher, as you say. And I think that we are beginning to understand that. But these capabilities are then downregulated as the individual matures.
Yeah. And then in this line of thought, do you think that as metabolic the metabolic capabilities are anyhow limited at some point, do you think metabolomics and so on can sort of give us more insights on whether we are exceeding the metabolic tolerance? Because I see some harm or some negative effect in exceeding the metabolic capability of a given individual. Do you see, have you ever sort of encountered paper or discussed with some people trying to address the issue whether too much nutrition or is somewhat exceeding the metabolic capacity of a single individual, therefore perhaps becoming harmful? And this, of course, apply to all at any age. This concept may apply to.
Yeah, absolutely. And I think that one of the areas has to do with the IUGR baby. You know, those babies have a different metabolism. And I think that several groups are beginning to recognize that, for example, their protein, their capability to metabolize protein is different than the appropriate for gestational age baby. And so this is where we need to understand the capability of that baby. So one of the things that I mentioned in the lecture is we do not have a metabolomic taxonomy in terms of what is normal. And that's one of the areas that I think we need to begin to focus on, you know, during pregnancy, during preterm life, what would be considered to be the norm. And then looking at individual babies and how they differ from that norm, I think can be very important in terms of designing the types of diets for those particular babies.
Thank you. Yes, I do agree with you entirely. We have a question here from Sai Kiran. Probably you can read the question yourself. And he says, Professor New, any role of probiotic drug in seeding the baby gut? If so, any particular preparation or mixture? And I add, if I may, I add another a little bit more sort of more complex, I would define, question. Is the maternal microbiome always good? That I would like to see. Well, let's go first and answer the question of the colleague of ours, and then
Sure,
discuss
sure.
whether the.
Well, when we talk about probiotics, there are, 200 or so different probiotics that are potentially available. And so one of the problems that I see is that people tend to talk about giving probiotics to babies. Well, which one are you giving to the baby? Which one are you giving to the mother? Which set of probiotics are you giving to that baby or to the mother? And so this is, I think, a major problem, because one probiotic is not the same as another. They have different capabilities. And so I think that studies need to be done looking at individual probiotic preparations. So that's very important. And in the future, I think we are beginning to recognize, looking at these multiomic kinds of techniques, that you can put together a set of microbes that have certain metabolic capabilities that are human microbes that have this set of metabolic capabilities that you can utilize for preventing disease in a particular baby. That's probably still 10 years down the road. But I think that that is a much more refined approach than just putting a probiotic into a baby's gastrointestinal tract. Your question, Virgilio, about the maternal microbiome, is it always good? No. I think that there are situations where we have a vaginal microbiome that, for example, does not contain the usual lactobacillus species. In a healthy vaginal microbiome, we see a certain very limited set of lactobacillus species. Whereas if you start seeing a large deviation from that, especially when you see things like urea plasma or the tenericute phylum, that is beginning to suggest a something that is potentially pathological that is associated with preterm birth. So you can have a microbiome that is not necessarily healthy. And certainly mothers who are very obese or who have certain kinds of diseases in their gastrointestinal tract, they have a different microbiome, and that will affect the baby. There's no question that that can affect the baby or the fetus.
Yeah. I mean, I think that this is one of the most fascinating topics. I mean, if you look at in ecology, you know, you have like microbiologists, scientists that works on bacteria that digest or get rid of unpleasant substances, metabolites, of that turn bad things into gas or other things like that. So, I mean, you know, we could also speculate, and perhaps I'd like to hear your opinion, whether we could the microbiome could complement some metabolic sort of inefficiencies, could sort of complement some metabolic inefficiency of the human body. Is there any research going on in inborn error metabolism in terms of, I have not heard much about it, whether you could scavenge sort of different molecule by the use of microbiome, the microbiome?
There's definitely research going on in those areas. You know, one example of some research is work that is being done in developing countries, where you look at babies. These are infants. These are not newborns or preterms, but infants who are not developing well. And you find that their microbiome and their metabolomes are different. And they are beginning to find that there's a certain ecotype or set of microbes that you can put into these individuals that may actually help them attain normal growth. And a combination of studies in animals and studies in babies are being done to look at that. So fascinating area. And you hit it right on the head with that question. Very important.
I had a chat on Sunday with an ecologist that is sort of developing bacteria, you know, to achieve a specific metabolic task in nature or in fermenters. It's really amazing. The science there is amazing. So it's, well, let me read, probably you can read yourself, but we have a chat. Corrado Moretti congratulates for the beautiful lecture. Yeah, and I do agree 100% with him. And there is a colleague or Conte, Diane Conte. I am a nutritionist from Canada. Do you think about, what do you think about enriched formula or enriched human milk with formula to help the premature baby to gain weight? Sometimes the baby doesn't gain weight and we increase to 24 or 26 kilocalories per ounce. Is it too much for the metabolism of the baby? Do you recommend to avoid these practices? This practice?
Well, if I recommended to avoid that practice, I would be telling a lie because I do that myself.
We do it.
Okay. So I will give babies 27, even 30 calories per ounce to try to get them to grow on their growth curve. Whether that is absolutely the right thing to do, I don't know. And this is where I think that this whole lecture on precision nutrition and where we are going in the future will, once we start getting that kind of data, we will be able to answer that question. But at this juncture, I am still going with the present, what we have available to us right now to try to keep those babies on the growth curves, to not have them growth faltering.
In spite of what your premise that this talk was not applicable right away to clinical practice, still you get question in clinical practice. Which probiotic, Dr. Gazeva, sorry, which probiotic do you use in the ICU for the prevention of nosocomial infection / latent onset sepsis? Is something you use in your practice?
No, we don't use, we don't routinely use probiotics. We are involved in a probiotic study, randomized controlled study of probiotics, but we are not giving probiotic routinely in our neonatal intensive care unit. In the United States, it's about 15% of neonatal intensive care units are giving probiotics.
I must say we share, I mean, we do the same, and for two reasons, perhaps we can discuss briefly. Well, when there is an intervention, it's always, order to be discussed, the magnitude, the number need to treat, or how big is the problem. In other words, when you read the paper that probiotics prevent sepsis or so, true or not true, you should always discuss how generalizable, how you can generalize this data obtained from study to your practice. And I must say we have like 8%, 7% sepsis. So the incidence of sepsis is not that great. So therefore we take this in consideration. And the second thought that, of course, I am sort of would like to hear your opinion is whether breast milk, it's something that could sort of compensate for the use of probiotics. In other words, what happened in our unit, for the sake of commenting with you, is that most of the baby, I would say nearly 100% of the baby, 95% get some human milk, and I would say 70-75% get own mother's milk. And I wonder if the natural probiotic effects of human milk is to be taken in consideration. What do you think, Joe?
Well, so there's a couple questions here, and let me try to address the first question about sepsis. And if you look at a study that was done in Australia called the ProPrem study, which was actually the primary outcome was sepsis, and they did see a decrease in sepsis using a specific set of probiotics. In that study, they did not see a difference in the babies less than 1,000 grams, however. Okay, so It depends on, it seems to depend on the size of the babies, at least in that particular study. In the UK study, the Costello study, they looked at, this was a prospective randomized controlled trial of necrotizing enterocolitis with 1,300 babies, saw no difference in sepsis or necrotizing enterocolitis. So it seems to depend on the probiotic, and we don't have a good idea of which probiotic to use in this kind of a setting. So getting to your comment, Virgilio, I think that human milk contains not only the potentially personalized microbes, but also IgA and so many other factors. If it's fresh human milk from the baby's own mother, and especially if there's contact between the mother and the baby, close contact, from a theoretical perspective, I think by far that is the best way to provide the protection to the babies.
Thank you. And then I think this brings us to what I think we should consider the last question for you from Valentina, which sounds a bit Italian, I guess. Valentina asks, can postbiotics represent a valuable tool to gain the same beneficial effect of probiotic with less risk for the premature infant?
Possibly, and there have been some studies that have been considering the use of postbiotics. So one example of a postbiotic would be the short chain fatty acids. Okay, short chain fatty acids, butyrate, propionate, acetate. Butyrate is thought to be very important in terms of maintenance of tight junctions. It's also the most important fuel for the colonocyte. So certainly that's a possibility, but the studies, there's only a few studies that have been done, and these are not that easy because you have to be able to get the right dose. And the kind of dose that we give exogenously is different than the dose that comes from the microbes in the gastrointestinal tract. Another example of a postbiotic is indole metabolites. Indole metabolites have been found to be important in terms of protection and mitigating inflammatory responses in the gastrointestinal tract. So I think that that's another area for investigation, but the actual results of studies and anything that we can utilize right now to guide our therapy is still not there. But I think it's a very bright area for future studies. Excellent question.
Thank you, Joe. I think we passed our time, 10 minutes past the time. And I would like to thank you again for this astonishing lecture. And as a continuation of this lecture projected to the future, I would like to remind you that tomorrow, 2 p.m. Central European Time, we have Professor Christoph Fuchs that will talk on enteral nutrition strategies for the low birth infant. So we have